Control of the airway is the single most important task for emergency resuscitation. I'm Dr. David Klein, an emergency physician and an editor for Tintinelli's Emergency Medicine. Oral tracheal intubation is a routine procedure for the emergency physician, yet no other procedure will save more lives. The basic sequence for endotracheal intubation requires 5 steps. First, simultaneous pre-oxygenation and preparation of the equipment. 2, administration of sedative agents and neuromuscular blocking agents to facilitate intubation. Number 3, utilization of the laryngoscope to visualize the larynx. Number 4, passing the endotracheal tube between the vocal cords. And 5, confirmation of placement of the tube and securing the tube in place. Now we shall see these steps in action. Here we see preparation of the equipment while the patient is being pre-oxygenated. In real time, the pre-oxygenation begins approximately 5 minutes prior to the actual intubation. In anticipation of drug administration, the patient's head is lowered and preparation is made for bag valve mask ventilation. Here we see administration of the induction agent, followed by the neuromuscular blocking agent. Pre-treatment begins approximately 2 minutes into the pre-oxygenation period and 3 minutes before intubation. These drugs are circulated until the patient's musculature is noted to be loose and spontaneous breathing has stopped. At this point, cricoid pressure is applied to prevent aspiration. The laryngoscope is inserted into the mouth and the glottic opening is visualized, which may require the use of suction to clear secretions from the posterior pharynx. First, you see the epiglottis and the introduction of the straight blade. You see it picking up the epiglottis and the vocal cords coming into view. Now you see the endotracheal tube being passed between the vocal cords so that the cuff of the tube is below the cords. Color change confirms correct placement. The epigastrium is assessed for absence of sounds, and breath sounds are assessed for side-to-side equality. The tube is now secured in place using tape. You have just witnessed an endotracheal intubation facilitated with the use of pre-treatment agents. We'll now examine each of these steps in detail. The indications for oral tracheal intubation include oxygenation, ventilation, protection of the airway, and the anticipation of a clinical course that might require preventative management, such as the care of a burn patient who has sustained inhalation injury. Equipment should be accessible when needed. Equipment shown here includes pre-oxygenation equipment such as a non-rebreather mask, a nasal airway, an oral airway, and a bag valve mask device. Equipment for the actual intubation procedure is shown here, including a laryngoscope handle, several sizes of curved blades, several sizes of straight blades, the Yankar suction, the endotracheal tube, a flexible wire stylet, and the syringe to inflate the cuff of the tube. Adequate ventilation and oxygenation must be ensured while the equipment is being prepared. Spontaneously breathing patients should be pre-oxygenated with a non-rebreather oxygen mask at maximal flow rates for 3 to 5 minutes.
Sir, go ahead and take 4 deep breaths for me.
Fully cooperative patient should be asked to take 4 maximal inspirations. Non-breathing patients should be ventilated using a bag valve mask device and using cricoid pressure to prevent aspiration. Vital signs must be monitored, and pulse oximetry should be used throughout the procedure. Intravenous access is typically utilized for drug administration, unless conditions allow for intubation without the use of IV drugs. The blade type and size should be selected. If the operator prefers to use a curved blade, a number 3 blade for a smaller individual, or a number 4 blade for a larger individual may be utilized. If the operator prefers to use a straight blade, a number 2 blade can be selected for a smaller individual, or a number 3 or a 4 straight blade may be selected for the larger individual. Once the blade has been selected, the light on the blade should be tested. In women, typically a 7.5 to an 8.0 tube is chosen. In men, an 8.0 to 8.5 tube. The balloon cuff on the tube must be tested. The end of the tube may be lubricated with a water-soluble lubricant. The use of a flexible stylet is recommended. The head of the bed should be lowered, and the patient should be positioned with the head extended and neck flexed, possibly using a roll towel underneath the occiput. If C-spine injury is suspected, the head and the neck should be maintained in a neutral position with an assistant performing inline stabilization. In most emergency department intubations, the patient should be given an induction agent and a neuromuscular blocking agent. The most common induction agent is etomidate at a dose of 0.3 milligrams per kilogram, and the most commonly used neuromuscular blocking agent is succinylcholine at a dose of 1 to 1.5 milligrams per kilogram. A more detailed discussion of medications for rapid sequence intubation can be found in Tintinelli's Emergency Medicine. After drug administration, cricoid pressure should be applied to prevent aspiration and enhance visualization. Technique using the straight blade is first demonstrated with the handle in the operator's left hand. The blade should be inserted on the right side of the patient's mouth and slowly advanced with the operator's eyes in search of the epiglottis. Suctioning may be required to clear secretions from the posterior pharynx. We now can see the glottic opening. It is not uncommon to go past the larynx into the esophagus. Gradual withdrawal of the blade will reveal the epiglottis. Lift the epiglottis to visualize the vocal cords. Now we see the tube being advanced and going between the vocal cords. We will now demonstrate utilization of the curved blade. The curved blade is introduced on the right side of the mouth, and the tongue is swept over to the left-hand side using the flange of the blade. The direction of the lift is along the axis of the laryngoscope handle. It is important to avoid levering the blade on the teeth to prevent dental trauma. From inside the patient's pharynx, we can see the tongue being moved to the left. The tip of the blade should be slid into the vallecula and lifted, an action that indirectly lifts the epiglottis to visualize the vocal cords. Once the vocal cords are visualized, an assistant should be asked to place the tube in the operator's hand, and it should be introduced into the patient's mouth. Pass the tube between the cords, avoiding force. The stylet should then be removed. And the balloon cuff inflated. If you are unable to visualize the vocal cords, the burp maneuver may be utilized. This procedure entails manipulation of the thyroid cartilage using backwards, upwards, rightwards pressure, which may bring the cords into view. If unsuccessful, reoxygenation may be required utilizing the bag valve mask device. The operator may consider changing the blade, the tube size, or repositioning the patient prior to further attempts at intubation. 3 unsuccessful intubation attempts define a failed airway. Further rescue techniques must be considered at this point. Successful intubation will be confirmed clinically with the auscultation of breath sounds, utilization of a CO2 detector, and pulse oximetry. Confirmation of correct tube depth will be made with the utilization of a chest X-ray. The majority of patients that require emergency intubation can be managed with the techniques described in this video. The emergency physician should be completely comfortable with these techniques and apply them to his or her daily practice.